Good morning, everybody. I am here with some enlightenment on today's segment of Coffee with Clinicians. I'm your host, Cyndi Gillum, and I am here with the esteemed Dr. Marissa Carter. She is a biostatistician and epidemiologist, EBM practitioner, health economist, and spends most of her time designing and analyzing clinical studies, as well as assisting manufacturers on medical devices and biologics approvals. And works in the fields of wound care, epidemiology, ophthalmology, orthopedics, and quality of life for patients. She is the author or co-author of over 130 peer-reviewed papers and book chapters in the medical and chemical research. Welcome, Dr. Carter, to Coffee with Clinicians.
Good morning, Cyndi, and good morning from Montana. Thank you for that kind introduction. And yes, I actually drink coffee too.
I love it. I was telling Marissa before we started that I think she might be actually the first person on Coffee with Clinicians to actually be drinking coffee with me. There's a bunch of tea drinkers out there. Can you tell our audience a little bit about the work that you do and let them know kind of what you work on and your background?
So when I was younger, I was accused of being a perpetual student, chasing endless advanced degrees in all the kinds of physical and chemical sciences that are known to man, you know. And so in a sense, I'm well grounded in a lot of different areas in science. And I started off in medicine and came back to it about 15 years ago. And during that time, you know, I have learned and also applied a lot of different things, some of the things that you mentioned. So having that knowledge and general approach gives you a little bit different perspective, because I work on a lot of challenging trials and projects, and sometimes I really have to think about you know, the 35,000-foot picture. So in that sense, we do a lot of these clinical trials and studies. I do a lot of systematic reviewing, some meta-analysis, massive amounts of peer reviewing. So you can all think of this as like the checks and balances in society to stop stupid stuff from happening, you know, and there aren't a huge number of people that do that around the world, but we're the ones that stop, you know, the own goals happening all the time.
Which is a good segue. So we find ourselves in this pandemic with, you know, the politicization of medicine, and it brings me back to what we all try to achieve, which is evidence-based medicine and wound care, because it's such a really new niche within the medicine realm. You know, new things come out every day, and it's difficult to sift through that. So why is research important to that concept? And secondly, what kind of research or technologies do you like to focus on in your research?
So the way we conduct research and the way we measure research are the two most important things. And it doesn't really matter what fields you work in. I mean, you mentioned the pandemic. We've seen a lot of stupid stuff going on. And most of that was because all the people that were talking about it, the so-called talking heads, didn't have any degrees, don't understand the science, aren't epidemiologists, know absolutely nothing of virus from a bacterium. And we allow that to go on. And there's nothing wrong with that. It's a free country. But that said, when we get serious and say, does this treatment work? You know, does this actually make sense? The people you really should be listening to are the people who have the credentials. You know, so that's a good example. And you know, we use evidence-based medicine as our second tool to really measure how well something works and whether it actually works at all, and whether we should actually be using it, again, regardless of what area of medicine you're in. You know, an EBM has been around about, I'm going to say almost 30 years now. It started in the early 90s. It has very specific structures. It's evolved. Lots of amateurs work in the field, make a lot of terrible mistakes. And the people who really learned it, again, are the ones like the goalkeepers that try to keep everything in order and say, yeah, this is good evidence, this is good systematic reviewing, etc.
I like it. There was, I think it was Dr. Serena who told me one time that you're an expert in something when you've made all the mistakes. But evidence-based medicine helps us prevent some of those mistakes.
Because we all make mistakes. I mean, some of the biggest things I've learned is from, you know, bad mistakes, and some of it is forgivable. It's like if you're working at the frontiers, you're going to make a lot of mistakes. Some of them, we will learn from. And sometimes when you're learning a subject and you really are learning it in depth, you're going to make mistakes. Hopefully they won't be too horrendous and, they won't end up in print.
Exactly. So with that, can you kind of give the people who are watching this, who may be laypersons, a high-level overview of what the levels of evidence are and where we put weight into some of those levels of evidence?
Okay, so we have this thing, it's called the pyramid. It's sort of, remember the food pyramid they used to teach you when you were kids, so it's analogous. But in terms of individual trials, at the very top, we have these randomized controlled trials. They're very controlled. They're designed to show effects in a quantified fashion. And people have criticized them by saying, well, they're not really applicable to real world populations. And that criticism is fair. So underneath that, at level 2, you have the observational cohort studies, which are designed for more real world populations. They're less controlled, but that said, really good cohort studies can outshine even RCTs if they're done well. And under that, you've got all kinds of cats and dogs in terms of comparative studies like classic case control. And then you under that have case series, case reports, and finally level 5, which is sort of like the PET, where you have expert opinion or not. Your grandmother's recipes of just about everybody else. And sitting on top of this pyramid is the summary of this body of evidence that underneath the systematic reviews and meta-analysis, and that has to be done well. Doing it badly is a disservice to all the stuff that's underneath it. So doing a proper systematic review and meta-analysis when it's appropriate tells us a lot more about what's going on in the entire body of evidence.
And if it's done well, it really does shine a light for clinicians who are practicing to see where that evidence goes, either good or bad, if this appropriately works or does not work appropriately in the right setting. And so I think it's vastly important when those are done to really look at, like you said, is the meta-analysis done well to support that evidence that's supporting it. And really, it is a guiding light for those clinicians who are prescribing. So with that, what can you say about where the research is going with oxygen, where it's been and where it's kind of going in wound healing?
So classically, when we think of oxygen in wound care, we think of hyperbarics. That's been around more than 80 years. It's been the subject of huge numbers of trials. And what we've learned ultimately is there are some niche areas in wound care where it works relatively well. It doesn't work well in a lot of areas of wound care, and it's taken a long time to figure that out. There are also a lot of issues with regard to knowing which patients it might work in and when to stop using it. By comparison, low pressure oxygen, we're talking about 1.05, 1.06 atmospheres versus 2.5. That's only been around the last 5 to 10 years. And this is continuous diffusion of oxygen into or across a wound. That's new technology, and the technology itself in terms of devices is still ongoing. But the evidence there, has been up and down. I mean, the last couple of years, private payers and Medicare have started to get focused on that. We have a huge project going on this year to look at systematic reviewing of all the trials done to date and the meta-analysis, and it's going well. Ultimately, I think it's something we will be able to use as a weapon in our armory to say that low pressure oxygen really does have a place in terms of wound care treatments.
And so, without saying what you believe the results will show, it sounds like you're saying that you do anticipate Medicare will actually grant something or, at least should consider granting a reimbursable code in the US for some kind of oxygen therapy.
I think so. It's sometimes hard to read CMS in terms of their due diligence, but at this point, I think the accumulation of evidence is going to make it a technology that should be considered more seriously. You know, it's a lot of things take a while to mature. You know, you invent something and you start doing trials, and you know, it's up and down, it's mixed, and eventually, if it really does work, you know, the evidence does shine through, and eventually you will cover it, you know, in public and private payers. So I think we are definitely making a really big step in the right direction here.
Well, I'm excited for that to come out. I don't want you to give anything away. And, you know, we do want to maintain your integrity as a statistician. I really appreciate you taking the time to speak with me today. I think it's very enlightening for a lot of people to understand the processes that we go through, not only with evidence-based medicine, but even bringing something to the market that can be paid for through the government. And it's just interesting to see that process take hold from start to finish. And I'm glad you're a part of it. Obviously, your background speaks volumes to your experience and knowledge, and we really appreciate you know, you contributing to the overall evaluation of that evidence. And so with that, I will bid you adieu for the day, but please come back, because we are excited to see what else that you have in store, not only for us, but other companies as well in this space.
Thank you for having me, Cyndi. It's been wonderful chatting with you about these challenging subjects.